Hi, Dr. Stanley here, and this is a quick medication fact about the medication lithium, also known as Escalith or Lithobid, which is a mood stabilizer. So, lithium is very effective in treating bipolar disorder, and so the book calls it the gold standard of mood stabilizers. But there are some issues with administration of lithium that we need to be aware of as nurses caring for these patients. They're not exactly sure how lithium works, and they think maybe it affects electrical conductivity. And what that means is that with bipolar disorder, they believe that there is this overactivity of neuronal electrical conductivity that is occurring, and they believe that lithium somehow stabilizes this electrical activity. They do know that lithium enhances serotonergic neurotransmission, and this may be why not only does it have properties that manage the mania, but also the depression side, where normally with other medications you might have to use an antidepressant and a mood stabilizer. So it does have these antidepressant properties, probably due to serotonin transmission and how it enhances that. And it also has anti-suicidal properties, so it can be good for patients who are acutely suicidal or have ongoing longer term suicidal thoughts. It does have lots of side effects though. And so some of the side effects and interactions are acne, alopecia, psoriasis, and of course, nausea, vomiting, diarrhea goes with almost everything because if we put something in our mouth and it travels along our GI tract, it's likely to cause some problems along the way. Hypothyroidism can be something that occurs with lithium use, weight gain, edema, polydipsia, polyuria, ataxia, sedation, and fine tremors. Almost all of our medications that we give in a psychiatric unit have that potential for nausea, vomiting, diarrhea, dizziness, ataxia, sedation. Almost all of them do. But interestingly, with lithium, you have to be really careful to be sure that you don't co-administer with certain medications that affect renal functioning or salt and water balance because it can alter the lithium concentration. And some of these are the NSAIDs, the hydrochlorothiazide, and angiotensin converting enzyme inhibitors, otherwise known as ACE inhibitors. And those are the ones, the blood pressure medications that end with the pril ending. Caffeine can decrease the levels of lithium in the blood, whereas these other ones would increase the levels. The onset of lithium action is going to be at about 10 to 21 days. So if you have someone who comes in who's in an acute manic phase of the illness cycle, they are going to administer the lithium alongside a faster agent, such as an antipsychotic or anticonvulsant or anti-anxiety medication, because the lithium is going to take a few days to become effective, and we certainly want to see our patient clear up before 10 to 21 days. Now, as I said, there are some problems with administration of lithium because it does have a very narrow therapeutic index or range, and this means there's a small window between what is required to be effective for the medication to work and what will actually kill your patient. So lithium needs to be monitored very frequently. In fact, every 2 to 3 days at first, and then monthly, and then every 3 months after that. So it is not a good choice for a patient perhaps who is unstable in their housing or they've been non-compliant in the past because of the fact that it does require this monitoring and it has such a narrow therapeutic range. Now, some things to know about lithium is we need to warn our patients to avoid any state that might cause dehydration. So if you have a patient who's going to be starting on lithium therapy, you need to let them know, hey, you need to be drinking, I think it's 2 to 3 liters is the RDA of water per day. You need to be drinking about 2 to 3 waters and 2 to 3 liters of water a day. And if you're going to go outside and do any outside work where you're going to be sweating, be sure to include additional hydration because if lithium becomes concentrated, it can become toxic very quickly, and then it's going to affect their renal functioning. Medication interactions also can lead to, interaction with the lithium to decrease renal functioning and alter those levels as well. And this can cause toxicity to develop very quickly. So as an example, here's our therapeutic range. It is 0.8 to 1.2 milliequivalents per liter. And so if it's not up to the 0.8, it's not going to work very well. And if it's above the 1.2, it's going to cause toxicity. So you can see this is quite a very narrow range that we have to be within in order for the medication to be effective and non-toxic. And as I said, I have had multiple patients who have been on lithium longer term, and some of them have had significant kidney damage when it has gotten out of this range during the course of therapy. So it's a great medication, but only if it stays in the therapeutic range. It does, again, take 7 to 14 days to even get to the therapeutic level. And we want to start low and go slow because lithium is a dangerous medication if we go too quickly and throw it into a toxicity level. So if there is such a narrow therapeutic range, why do we still use lithium? Well, the benefits of it are amazing as it does help to control depression and it helps to control the mania side of bipolar disorder. So it can be like a one-stop medication for controlling everything. It does reduce the elation of patients experiencing mania and their grandiosity and their flight of ideas, anxiety, and even suicidal and self-injurious behavior. It can also help with insomnia, paranoia, distractibility, hypersexuality, threatening, assaulting behavior, and psychomotor agitation. Of course, you can imagine that there are some contraindications with lithium, especially with the side effects that can occur. And some of these are cardiovascular disease, myasthenia gravis, and of course, renal and thyroid disease, since lithium in toxic ranges can cause damage to the kidneys and to the thyroid. Brain damage is another contraindication, as are pregnancy and breastfeeding. Now let's go on to the toxicity levels and signs and symptoms. So first of all, up to 2 milliequivalents per liter, so that 1.2 range to 2 milliequivalents per liter are the early signs of toxicity. And this is going to be GI symptoms. That fine hand tremor is going to progress to a coarse hand tremor, altered mental status, hyperirritability of muscle groups, ECG changes, sedation, and incoordination. Now, if you're at this level, we're going to hold the medication. If you see these symptoms, you're going to hold the medication and get a lithium level. And of course, you're going to get the order from your provider to do that. You're going to call and say, hey, these are the symptoms I see. I think we should hold the med and take a level. Can I have an order for that, or what do you think we should do? The next range is 2 to 2.5 milliequivalents per liter, and this is where we're going to get into more signs and symptoms, such as a large output of dilute urine, because you can imagine it's starting to affect the kidneys at this point, ataxia, giddiness, serious ECG changes, blurred vision, clonic movements, seizures, stupor, severe hypotension, coma. Death is often secondary to pulmonary complications that do occur when the toxicity level reaches this point. And of course, at this point, because we've got some pretty serious stuff going on, like seizures and pulmonary complications and coma and all of this, we're going to hospitalize them and hold the med. And you may even wind up irrigating the bowels to prevent further absorption of the lithium. Now, once we get above 2.5 milliequivalents per liter, we're going to see convulsions, oliguria with little or no urine, and even death. And they may use hemodialysis at this point to try to get rid of any lithium that could still be, present within the bloodstream to try to keep it from going any higher. So we never want to get to these points, and this is why it's important to monitor our lithium, to teach our patients that they need to, stay hydrated, to teach our patients not to change their salt consumption. So basically, the lithium is going to wind up kind of stabilizing in the therapeutic range based upon their normal diet. So if they're going to change their diet and they're going to stop using salt or start using salt or whatever, we need to make certain that we let them know that, that they tell their provider that that's occurring, because otherwise, if they change it suddenly, remember the fluid goes with salt. And so we could wind up seeing, large fluid volume shifts. And so anything that could change that, we need to be careful of. Any kind of diuretic or something that they start on or things like that, we need to be aware of and make certain that their provider is aware of when they're prescribing the medication and obtaining blood levels. So it may be that they change the dose and that they monitor it more closely for a little while if changes are occurring. So anyway, like I said, lithium is a wonderful medication, but there's a lot of nursing actions that need to kind of go along with this, and things that we need to watch for as nurses who are administering lithium, and make sure that our levels are being drawn properly and that we're monitoring those quite closely.